Welcome to another Prodigy EMS webinar. We are very pleased that you're joining us today. Today's topic is circulation first, resuscitation and pediatric trauma. And we are very grateful to 410 Medical, maker of the LifeFlow, for their support of this education. I am Hillary Gates, Director of Educational Strategy at Prodigy EMS. Caring for critically injured children has proven to be one of the most stressful call types for EMS clinicians. We all know this. And for these complex pediatric cases, we must prioritize circulation. Today, we have two subject matter experts with us to review both the evidence and the practical application for the care of critically injured children. Peter Antevy is a pediatric emergency physician, an EMS physician, and the founder of Pediatric Emergency Standards Incorporated. He's the medical director for numerous agencies in Florida and the lead pediatric EMS specialist for the highly influential Eagles. And we also have Mark Piehl, who is a pediatric intensivist at WakeMed in Raleigh, North Carolina, and he is a medical director with WakeMed Mobile Critical Care. Dr. Piehl has faculty appointments in the Department of Pediatrics at the University of North Carolina and Duke University, and he teaches pediatric emergency and critical care skills to learners at all levels. He is also the founder and CMO of 410 Medical. We want to hear from you during the webinar, so please post your questions in the chat or in the Q&A box, and we will do our best to address them by conducting a live Q&A at the end of the presentation. Peter and Mark, take it away.
Thanks, Hillary. Appreciate the introduction. Hi, everyone. It's Peter Antevy, and I do have a disclosure that I founded a company called Antevy, which you will not hear about today, and looking forward to the conversation.
And I'm Mark Piehl. My disclosure is that I'm founder and CMO of 410 Medical, which makes the LifeFlow, which we'll mention briefly today. And I also have numerous Department of Defense grants for trauma resuscitation that you should be aware of. So let's get started. We're going to do a high-level view of pediatric trauma, go through a few cases, and then help everyone understand why we need to focus on circulation first when we're approaching a critically ill child who's been injured. So it's worth remembering that pediatric trauma is responsible for more deaths than any other cause of death. And in fact, it's responsible for more deaths than all other causes of death combined. Meaning that if we take all the conditions that we care about in pediatrics and put them together, 60% are related to injury. The biggest two causes being motor vehicle accidents and firearm related injuries. There's a lot of other important diagnoses we could care about: cancer, sepsis, you name it. But in terms of cause of death and ability and opportunity to impact and improve the lives of kids, understanding how to provide trauma care, especially in the early minutes, is likely to improve the lives of the most kids, and something we should all care about. Sadly, I want to just point out that, as you are probably all aware, firearm related deaths are climbing, and this is now old data, 3-year-old data, but from 2019 to 20, we saw a 30% increase in gun violence and gun related mortality in kids, and that trend has not stopped. A little guy that's probably taught me more about pediatric trauma than any other patient I've cared for. A 2-year-old attacked by a dog in a backyard of a neighbor's house. The local paramedics packed him up quickly after the dog was restrained, brought him to our trauma bay, and we found him unresponsive, but spontaneously breathing, with massive injuries throughout his body. An entire half of his face gone, multiple bite wounds to the thorax, abdomen, and extremities, multiple big chunks of tissue, sadly, were taken out. And here is his initial vitals. Initially tachycardic. We're going to talk about tachycardia, or heart rate, as the most important vital sign in kids. And then he becomes relatively bradycardic. What does that mean? That means he's about to have a cardiac arrest. Hypotensive for a 2-year-old, was breathing and has no detectable O2 sat, probably because he's poorly perfused. I could note that his mucous membranes were pink, so I thought his sats are okay, but he was so poorly perfused that he couldn't pick up a sat. This was his initial film. You don't necessarily need a film, obviously, to diagnose a tension pneumothorax, but I just wanted to show you the extent of his injuries. So a tension pneumo here, where the dog bit through his chest wall, and then he has tension physiology, meaning pressure developing on that side of the chest, which further impairs his venous return. He has long bone fractures from the bites, big chunks of tissue taken out of his body, a super sad case, and a child that was about to die in front of us. Wow, when you approach this child, what in the world are you going to do? What's the priority here? And Peter, we've talked about this case before, but there's not necessarily a right answer. But if we were to intubate him first, it's possible that he'd have a cardiac arrest before our eyes. And so this one illustrates the need for circulation first resuscitation, meaning getting him hemodynamically stable so that we can address all these other complex problems. Any comment on this one, Peter, before we move forward?
Yeah, I think it's so important that you're talking about this particular case with trauma. And when you talk about circulation first, it's really, we're talking about circulation before the advanced airway. And I'm sure that we'll get into the physiology that occurs when you are paralyzing somebody and what that does to that child who, like this one, is holding on by a thread.
Yes.
And by doing the wrong thing first, you snap that thread. And I think that this particular case, and I know this case it means a lot to you, and it kind of gets you emotional because of how sick this kid was. But I will say that people who are listening today need to understand that you do have to do circulation first before you go to the advanced airway for that exact reason.
Right. And we'll touch on it throughout the talk, but let's just think about the physiology of him at the moment, okay? So he's hypovolemic, presumably because he's lost blood from multiple sites: face, long bones, chest, elsewhere, and soft tissue lax. And then he has tension physiology, meaning every time he breathes in, he actually has a ball valve effect through these chest wounds, sucks air into the right chest, and that increases the pressure on the lung and the heart, further impeding the amount of blood that gets back to his right ventricle. As he breathes spontaneously, he's actually able to draw in some blood to his right ventricle by negative pressure and augment his venous return. But if we take that away with a paralytic, and then we apply positive pressure into his chest, we could actually prevent any blood from returning to the right heart. And again, then guess what happens? He has a cardiac arrest, and one from which he is unlikely to survive. And all the while, that hypotension is potentially making his traumatic brain injury worse. So thinking about restoring the circulation first, even though his airway is about to go, applying oxygen, which we did, getting blood into him rapidly through an IO, which we did, and then getting the bleeding tube in was key. A quick pediatric pearl I like to remind myself of, and you guys of: ABCs, yes, but don't ever forget the glucose, D, E, F, G. This child ended up being hypoglycemic as well, and toddlers and infants will be under great stress hypoglycemic. And so we should not neglect that AccuCheck, even in these intense situations. So the points we want to address today are just those: resuscitate before you intubate. Think about the circulation first in severe hemorrhagic shock from trauma. Remember, hypotension is deadly in kids, particularly when you have a traumatic brain injury. And we're going to talk about the need for us to give blood and TXA earlier out into the field when possible. The problem we're addressing is simply shock. Not enough in traumatic hemorrhage, not enough blood and oxygen molecules getting to the tissues that need them. So supply of oxygen imbalance with the demand for oxygen. And what causes shock in trauma patients? Well, it's mostly hemorrhage. It's mostly bleeding to death. But as you heard about in one of our patients, tension pneumo can produce physiology that reduces good cardiac output and causes shock. Tamponade as well. We don't see that often, but cardiac tamponade from trauma can do it. And then neurogenic shock from a high spinal cord injury can result in vasodilation and hypotension. But we should always assume that there is bleeding when we have a patient with hypotension and make efforts to stop that bleeding and restore the circulation. ATLS reminds us to think about where the bleeding might be. Much of it is often left on the street from the injury, from the scalp, or from the soft tissue wounds that the child may have. Blood can hide in the chest. A hemothorax can hold a lot of blood. Intra-abdominal hemorrhage, pelvic fractures as well, and then of course long bone fractures. All of these can lead to life-threatening hemorrhage. How in a child in particular do we recognize shock? Well, mental status, it's simple things. Altered mental status, which can be confounded by traumatic brain injury, of course, in multi-system trauma. Cap refill, so cap refill under 2 seconds is what we want to see. The quality of the peripheral pulses, the heart rate, which we'll address in a minute, and then an end tidal. If you can get it on and have end tidal CO2 monitoring, end tidals somewhere around 25 or less indicate that the patient is likely in shock. In kids, heart rate is the most important vital sign. Kids on the red line here have the ability to maintain blood pressure at relatively normal levels until far down the line when they become decompensated, meaning they can maintain a high systemic vascular resistance, squeeze the blood vessels down, maintain blood pressure, and maintain cardiac output simply by increasing their heart rate. So high heart rate in a child should alert you to a potential problem. And it's in this phase where we have high heart rate and other markers of diminished perfusion, but yet a normal blood pressure, where we can intervene, where we can intervene in sepsis with fluids, where we can intervene in trauma with blood transfusion and address that shock early. Remember the calculations, and Peter, this is in the Antevy app as well, reminding us of the normal blood pressure ranges for a given child. But if you just want to calculate it on the top of your head, I love the PALS recommended 70 plus twice age rule. So from ages 1 to 10, 70 plus twice the age is the minimum systolic a child should have. And anything under that is considered hypotension. Under a year, under 70, under a month, under 60 is considered hypotension. And then for 10 years and older, everyone under 90 is hypotensive. Quick thought on a shock index, which sometimes is a confusing concept, but takes into account the fact that a patient may be in shock without hypotension. So when you add the heart rate into the systolic blood pressure and calculate it as a simple heart rate over SBP, you can get the number, the shock index. And all of us sitting here who are not in shock at the moment have shock indexes under 0.7, under 0.5 likely. But if the heart rate in a 10-year-old and older patient equals or is above the systolic blood pressure, that's a significant indicator of shock. And the higher that number is, the more they are at risk of bad outcomes or of dying. So this gets a little confusing in kids because remember, heart rates our baseline heart rates are higher in kids. But in your older pediatric patients, adolescents, and adults, anything over 1 should alert you that there is blood loss or some type of shock going on. We need to remember that hypotension in kids is a late finding. Remember, that's decompensated shock. And turns out it's the single biggest risk factor for death in a kid with trauma. So hypotension on arrival to the trauma bay means the child has a 12-fold risk of dying compared to those who are not. So if we can recognize shock, treat it early, and particularly treat hypotension early in the field, we will provide better outcomes for our trauma patients. So how do we treat it? Well, ideally, we'd give whole blood. Peter, your agencies are beginning to give it. I know Broward sheriffs are giving it as well. A lot of agencies around the country are starting to give blood in the field. It's still a minority. It's coming and becoming more frequent. And the places that have it are seeing incredible outcomes. So fresh whole blood is the ideal transfusion or volume resuscitation fluid. In the hospital, when we don't have whole blood, we use what's called a balanced ratio, meaning we give the red cells, the plasma, and the platelets ideally in equal ratios. That's hard to do. Plasma alone can be an effective resuscitation fluid if blood is not available. And then fluids, which is a controversial topic, but there are cases where even in a trauma patient, we'll have to give fluid because we don't have blood available. We're always trying to avoid the lethal triad of hypothermia, coagulopathy, and acidosis, which afflicts severely injured patients. We can do this by avoiding exposure and warming the patient, by giving warmed blood or fluids, ideally, by giving less crystalloids, because a lot of fluids can exacerbate the temperature, acidosis, and coagulopathy that trauma patients get. But most importantly, we can correct shock early. We can recognize that a patient's in shock, and we can restore that perfusion by transfusing early if possible, and using crystalloid in certain cases, which we'll discuss, particularly with TBI if we have to. You may have heard, and it's out there on Twitter and on blogs and in articles, that all salt water, all saline is bad for all trauma patients. And this image from a tweet a number of years ago suggests that any clinician who ever gave a dose of fluid to any trauma patient is a bad clinician, worsening that with lethal triad. That thinking is not wrong in the hospital where we tend to give too much crystalloid, but a modest amount given for a patient with TBI, in particular with hypotension, can be life-saving. And in fact, there are good pediatric data which suggests that a modest amount of crystalloid is safe and effective. This is a big study of 1,400 patients, kids with elevated shock index. They adjusted the shock index for age here. And they looked at kids who got more than 20 per kilo of fluid and saw how they did. Interestingly, kids who got 20 per kilo of fluid often didn't need any blood. They got a 20 per kilo fluid bolus and they did well and needed no more than one. Pretty impressive. And kids who got more than one crystalloid bolus, so let's say 40 per kilo, had one adverse outcome, which was a slightly longer time in the ICU on a ventilator. But what this suggests is that a 20 per kilo bolus of fluid is safe and effective and can be used as your resuscitation fluid if necessary, if you happen to be in an agency where there is no blood available and you have a hypotensive patient. So 20 per kilo early on can be effective. And it's in fact was used in the big EPIC TBI study we will discuss later. A quick note here on LR versus saline. Lactated ringers, which we often think of as maybe a better resuscitation fluid in sepsis because it's less hyperchloremic and less acidemic or acidotic, is not a great solution for traumatic brain injury because it has a low sodium content. And so we may actually make the swelling, the brain swelling worse if we're using LR or hypotonic solutions. So saline should be our fluid of choice in a patient with hypotension and traumatic brain injury.
Just one quick point. I'm sitting here, I have a can of Gatorade, right?
Yes.
There's about 340 mLs in here, right?
Gotcha.
5-year-old, this is the 20 per kilo bolus
There you go.
for 5-year-old. So I don't want people to think of 20 per kilo as being something so dramatic. It's
That's right.
essentially a can of water, right? So that's why people should never hesitate to at least give that first 20 per kilo.
I agree. Excessive fluids, we can both agree, can cause harm, but that's mostly happening in our ICUs, Peter, in the hospital, not out in the field, right? Potentially in the ED, but rarely even there. ATLS, there's controversy about ATLS, understandably, but they're still recommending a liter of warmed crystalloid for adults as the initial fluid. If blood is available immediately, give it. But if you don't have it immediately, it's okay to start with crystalloid, 20 per kilo for kids. And then for kids in particular, we then go with 10 per kilo doses of blood until their circulation is restored. Ideally whole blood. Early transfusion, we know from military data in the field saves lives. And guess what? It had to be given early within the first 15 minutes of arrival of a medevac team to these combat casualties. Everyone else didn't show a survival benefit, but those who had time to transfusion of less than 15 minutes from arrival of the medical team did a lot better. They survived a lot more often. And we can apply that in the civilian world and say the further we push resuscitation to the point of injury, the better our patients are going to do. We're going to show you some data on that in a minute. By the way, why whole blood? Why not just the pack cells we've always used? Well, it's what our patients are bleeding, and let's give that back to them in the same form they bled it with all of its important components. It's very difficult, as we often find in trauma situations, to really reconstitute a pack cell plasma platelet mix of 1:1:1. So whole blood is just simpler and has other benefits as well. What is whole blood? Is simply just what you donate at the blood donation center without breaking out the plasma platelets and red cells into their separate components. And now there are increasingly good data that it's safe for kids. A lot of this comes out of University of Pittsburgh, which is where Peter trained. And there's a number of studies showing that kids who get whole blood as their first resuscitation product have better outcomes. Let's also remember in trauma patients that minutes do matter. And this is a great recent trial reminding us that for trauma patients with hypotension, this is adults, but applies to kids as well. Every single minute in delay getting blood or TXA was associated with increased mortality. How can we argue with this, Peter, that we need to be pushing these therapies closer to the point of injury? So we're going to show you just quickly a bit of data here from some of the agencies we're working with. This is from New Orleans, where we looked at the implementation of a program where this was being done, giving TXA, calcium, and 2 units of packed cells. They didn't have access to whole blood yet in that agency, but they're giving these products as a bundle, an advanced resuscitative care bundle, quickly to patients in the field who have hypotension and penetrating trauma. In this study, head injury patients were removed and cardiac arrest patients were removed from the analysis. And what they found is that shock index in a very short 8-minute transport time or 9-minute transport time could be reduced from very high, 1.4, predicting a high mortality, to almost normal within that time. And that the mortality of these patients who would have an expected mortality of 30 to 40% is now 10 to 12%. And interestingly, in this same study, and we're going to present this at a bigger national meeting soon, compared to patients who did not receive blood, those who got this advanced resuscitative care bundle rapidly in the field in short transport times needed very few, if any, pre-hospital intubations, meaning they were resuscitated, their mental status improved, and they were able to began maintaining their own airway so that a heroic intervention didn't need to happen. And this is all occurring, this is downtown New Orleans, in a several mile, 7 radius with a 7-minute transport time to the center, a time at which most people would say that's too short. That's too short of a window for us to even bother providing this resuscitation. And Peter, in some of your agencies, we have similarly short transport times, I believe, especially with the helicopters.
Yeah, and Mark, I think that last slide where you showed the significantly lower number of intubations, look at that, 2%. And when you look at that number, everything finally starts to gel together, where the circulation fix, if you will, that whole blood, and in their case, the packed red cells, obviate the need to intubate somebody. And so imagine the morbidity that you're saving, let alone the mortality, right? These people who don't need to be intubated are sparing themselves days and days in an ICU. They're getting home a lot earlier. It's that early treatment that you're talking about that's sparing them many more complications down the line.
Absolutely. And I think these data are beginning to prove that if you resuscitate, you may not have to intubate. And we know that pre-hospital intubation is associated with some complications and sometimes deadly complications. Not that it shouldn't be done in the right cases, but if we can prevent it, great. Peter, data from your own agency here, you just published quick study, similar protocol using whole blood and TXA, no calcium in patients with traumatic shock. And you found that, and by the way, you're giving blood to kids, right? 10 per kilo of whole blood if they need it. And
that's correct.
Directed recess.
Exactly. It's all ages, and if it's under 5, we're like a call, but that's about it.
Yep. And you've shown in the patients who did not have a traumatic arrest on the scene, again, a 10% mortality, which is much lower than would be expected given the severity of injury these patients have. So we'll quickly move now to how do you then resuscitate? How do we get that blood into the patient? Lots of methods are used, pressure bags, gravity. In the hospital, we have fancy pumps that sometimes work, sometimes don't. This is the push and pull technique with a syringe. Most of the time, we resort to this, holding a bag up and hoping it works, holding it even higher and hoping more that it works to resuscitate that patient, which it may or may not. Problem is, this is the same technique we've been using since World War II, gravity, holding a bag of plasma up a few feet above the patient's head and hoping that it is infused rapidly. Some of our military providers will use that push and pull technique here. You see on the left picture, the syringe and stopcock to manually push it in. And then in the hospital, we have all these other techniques. Peter, what you and I have taught for years is actually the push and pull technique, just using a syringe and stopcock. And we find that works, but it's cumbersome and comes along with its own complications. And Peter, this is what we used in the patient I presented before. There's the tibial IO. Again, we'd use a femoral now, but that's how we had to inject the fluid or the blood to get it into the patient rapidly. The LifeFlow device I mentioned before is what some of Peter's agencies are using now. And the data from New Orleans comes from this method of infusion, which allows the paramedics to get that unit of whole blood in more rapidly when minutes really matter,
Mark,
in 3 to 5 minutes.
Yeah, I'm going to comment on this because I can tell you that we are looking around the country at what other people are doing, and we're hearing the stories and so forth. And it turns out that we are seeing these patients, like you said, they literally wake up right? We had an officer who was shot in the groin. Within literally 2 minutes, as the blood was going in, this guy, the officer, he opens his eyes and he says, "Give me more of that." So there is no doubt our hospital uses LifeFlow. My agencies use LifeFlow. There is no doubt that this has to go in quickly, and even wasting another minute or 2 or 3 or 10 or 15 minutes, we cannot afford to do that. And the other beauty of this, Mark, that you probably know this already, is that we're not staying on scene to do any of this stuff. This is all being done literally en route to the hospital, as fast as we can get it on, especially when we have to intercept the blood to the with the ambulance. It's halfway to the hospital. The EMS captain just jumps on that rig and gives the blood en route to the hospital. So there's no excuse. That 7-minute graph or map you showed, I don't care if you're 2 minutes away from the hospital, we need to do that.
Absolutely. And you're showing that paramedics can now provide effective critical care when minutes really matter, and bring a patient to the hospital in a much better hemodynamic and in GCS state, as you described, such that sometimes the physicians in the trauma bay don't believe the paramedics that they were as sick as they were at the scene. In fact, the one you mentioned, I think the surgeons didn't even believe it, that he was had been in shock before and now is talking to them. What about access quickly in kids? I showed you the tibial IO in my patient. It turns out that femoral is probably better because that bone is bigger. You have a lot more bone cortex that grabs the IO needle and holds it in place. It's closer to the femoral vein. A couple caveats in kids are you've got to use a bigger needle. The pink needle will not work in a femoral in anyone, even an infant probably, and we got to use the yellow, blue or yellow to get through that femoral. I like the landmarks of 1 to 2 finger breadths above the patella, straight down through the patellar tendon. Peter, I think you're advising going a little medial. I think both are valid, and as long as we're using the femoral approach, I think we'll have better access in kids who are tough to get access in.
100% agree with that. The flow rates are just as good as the humeral flow rates, and if you're gonna get blood in quickly, you really need to use either the proximal humerus or the distal femur. I think that proximal tibia is really, it's a thing of the past for most of these cases, unless a child's fully awake, let's say, and the distal femur does hurt because that plastic spins against the skin.
Yep.
So in the fully awake child, I probably would not do
Good
a
advice.
Mm-hmm. Yeah.
Humerals, I'm not expert at as a pediatric provider. I think in bigger kids, I mentioned the 7-year-old, we used one. It's a great placement, and especially if you have lower extremity trauma or pelvic trauma or abdominal trauma, it's probably better to be infusing the blood into the humeral head as opposed to a femoral or tibial IO. Quickly, I get a lot of questions, I'm sure you do, Peter, on tourniquet use in kids. Who is too small to use a standard tourniquet? This is an image of a small child, noting that for a big artery laceration, we can actually get pretty good control just with direct pressure, getting the femoral artery, for example, or vein trapped up against the bone, and holding direct pressure as an effective tourniquet. Tourniquets will work in extremities that are about 6 inches in diameter or bigger, and that's estimated by the OK sign with about an inch between your fingers. That's about as big around as a cat tourniquet will work. Okay, so about the size, or a little bit bigger than our wrist. If the child's extremity is smaller than that, standard tourniquets are too small, and so we have to either use direct pressure or the cravat technique. And I'm going to show you this video real quick that I was able to get from my friend Scotty Ballader, who's published on this. An alternate method of tourniquet application in a child for whom a cat tourniquet is too small. So here's a bleeding model. This is a cadaver. Direct pressure trapping that, in this case, brachial artery up against the bone. You can see it compressed on ultrasound. And then taking a length of cloth or parachute cord, it's shaping it into a U shape, bringing that U under the arm. We then bring both ends of the cord through that U and pull them in opposite directions. And that will result in enough constriction to act effectively as a tourniquet. It's a great technique. And this comes from an Air Force PJ that we've worked with, who had to respond to a mass casualty in one of his deployments, a pediatric mass casualty, and use this effectively in multiple patients. That's a great tourniquet technique in small kids. So just a little pearl we wanted to add in.
And Mark,
All
the SWAT T, that little, it basically looks like a big rubber tube.
Yep.
That's also something that people could consider in smaller kids.
All right, Peter, let's move quickly to the EPIC TBI study, which is a really important part of our circulation first concept.
All right, Mark, that was amazing. What I want to do is talk about a paper that came out years ago, and it goes exactly to what you're talking about. So I know many people have heard about the EPIC study, but what I decided to do today is I'm going to start off with some multiple choice questions to see if you gain some experience from what Mark was talking about. So here's a 17-year-old male struck by a car, seen safe, law enforcement is present, see some alcohol on board per PD. However, this patient has a GCS of 3, obvious TBI, has a leg fracture. Look at the vital signs: blood pressure 140/80, heart rate 96. I'm sure you're all doing a quick shock index there. Hopefully you are. Breathing 10 times a minute on his own, statting 96%, tolerates the OPA. So given this information, what would you do? Would you nasal cannula 4 liters per minute, throw on a non-rebreather at 15, BVM at 10 breaths per minute, or would you intubate and then breathe the patient at 10 breaths per minute? So more than likely, especially if you're thinking how we used to think, most people are picking one of these choices, but let's continue and I'll show you the answers at the end. So 5 minutes later, the patient is still breathing on his own at 10 to 12 times a minute. SATs are now 100%, but now that blood pressure has significantly dropped. Now, if you remember what Mark said, that blood pressure is still above 90, so we're still okay.
It's fine.
However,
That must be fine.
it must be fine. Leave it as is. And you can see the heart rate is 130. So next question is, what do you do next? Is it 1 liter wide open? Is it IV fluids only when the blood pressures go below 90? Or is no IV needed? And remember, this is an agency that doesn't have whole blood. Okay, so what I wanted to do is talk about the types of TBI here. And what they describe in the article is that there's really like 3 categories, right? You have the greens, which are calling, mild and moderate. Those are the walkie-talkies. They're walking on scene. There's nothing you can do to screw those patients up for the most part. Fine. The critical ones on the right-hand side are the ones who have brain matter exposed. They have blown pupils. You're probably not going to do anything to help those people out. What they've learned with EPIC is that the people that we can actually save and make a big difference is the middle category, the severe category. So remember, when we're talking about EPIC TBI, we're essentially talking about one category, and you can think of those patients as they're altered of some sort. They've had LOC, their GCS is not normal. That's the patient that we're talking about here. What did they do? So really quickly, huge study, 21,852 patients. There was a pre-implementation study where they looked at the before, and then they actually just did this educational intervention, which we're going to do a little bit of right now. And then they looked at actual patients after the implementation. Big study, the whole state of Arizona, 133 EMS agencies. It took them 8 years to do it. And all they sought to do was 3 things. They wanted to avoid hyperventilation, hypoxia, and hypotension. So I actually have a couple of the slides from their PowerPoint. And just to show you that in age under 10 years, that they aggressively wanted to prevent hypotension. And Mark said earlier, that's 70 plus 2 times the age. And if that's the case, they wanted to give a 20 per kilo bolus, then a repeat 10 per kilo bolus, and then to keep the blood pressure above the threshold. And at that time, 70 plus 2 times the age is the 5th percentile. It's the lowest acceptable blood pressure. You'll see later that after they got the results of the study, they're going to modify that number now so that we can utilize that in our agencies. If you're over 10 years of age, as Mark mentioned earlier, the threshold was 90 for the systolic blood pressure. Again, 1,000 mLs of crystalloid, repeat 500, and then keep the SVP greater than 90. But remember those numbers again, because that's going to be modified based on the results of this study. Again, this is all the PowerPoint that they used prior to the study going live.
And Peter, it's key on that slide, but it says begin before they're hypotensive, right? Which is where the shock index comes in.
Okay, so we talked about it, avoiding hypoxia, hypotension, hyperventilation. This all sounds so easy, right? Because when you tell someone in the field, hey, you just got to avoid these things, I think this is probably not the right thing to say. You have to be very, very specific. And I would change your protocol to be very, very specific. And so what I put in my protocols is, as soon as you get on the scene, the first thing that patient needs is a non-rebreather, period, end of story. And if they're in that severe category, automatic non-rebreather. I don't care what their SATs are. Then you look at hypotension, and we looked at the blood pressure, and we'll talk about that more in a minute. But let's talk about hyperventilation, because a lot of protocols talk about, do we hyperventilate and bring the end tidal even lower, and et cetera. They were very clear on this study that they wanted to keep the end tidal within normal range always. It didn't matter if you had a blown pupil or not. They say that the blown pupil patients are not going to do well anyway. And they didn't want people hyperventilating to get to end tidals below 35, because we know damage is done there.
Mm-hmm.
And then the ideal respiratory rate, if they're breathing 10 times a minute for an adult, 25 in infants, and 20 in children, if you at least hit those thresholds, then they're doing just fine. So you had the patient here who had a GCS of 3, but remember, the patient I gave you was breathing 10 times a minute. And so the question is, what do you do in that particular case? We'll get to that in a minute. So again, I told you how many patients were in the study. Let's take a look at the results. First, it's very important to understand that when you look at this adjusted odds ratio on the right, when you see that dotted line, the 1, if you see the data point and the whiskers to the right of that line, then that means that this strategy of avoiding the 3H bomb worked. And lo and behold, the only time that you saw benefit from avoiding the 3H bombs was in the severe category. So these are patients who did not require intubation, no advanced airway. You can double the increase in survival to discharge just by avoiding these 3 things, which is amazing. Let's go to the next one. So now we're going to go to this slide, which shows severe TBI with an advanced airway. And you can see that, again, if they were in the severe category, you can triple the increase in survival to discharge by actually avoiding the 3H bombs and still putting in an advanced airway. So we're not here telling you not to intubate the patient, but what we're telling you is that do it properly, do it in the right order, and don't start paralyzing someone who's got a very soft blood pressure and then they go into cardiac arrest simply from the act of intubation. Because of what Mark mentioned, you're just basically removing any opportunity for the RV to fill, and basically they go into cardiac arrest right on the spot. Part of the paper and part of the outcomes, you need to know this information, because if you have just one episode of hypoxia, the outcomes are 5 times worse. What about hypotension? One episode of hypotension is a 3-fold worsening in outcomes, but then if you put those 2 together, just 1 and 1, you have a 17-fold worse chance of an outcome. And so when you're on a patient who has severe TBI, you must address the hypoxia first. That should be the first thing you do, non-rebreather. And then you need to address their hypotension because of the additive danger of both of these together. So when the paper came out initially, there was rumors that these blood pressures that we call permissive hypotension in the trauma patient were not effective in TBI. And I searched through the paper, I read it 100 times, and it turns out that they didn't write it up in their first paper. They waited, and then they put out this information a little later on. It was a separate paper. This is important information, and I know it's going to upset some people, but if you have a multi-system trauma that has severe TBI involved, permissive hypotension cannot be part of the vernacular here. You really are harming the brain by letting this patient kind of hover in, like, let's say 80 systolic because they have a good radial pulse. You can't do that with TBI. And in fact, that number turns out to be much higher. And so when you look at your protocol, when you may have something that says normal saline only enough to maintain peripheral pulses for hemorrhagic shock. But what about TBI? You really have to change that number. And we have done that in our protocol. Here is the follow-up paper, optimal out-of-hospital blood pressure in major, or let's call that severe, TBI. And it's a challenge to the current understanding of hypotension. And it really is a challenge because some people still aren't wanting to believe it. When you look at hospital length of stay, discharge to rehab, ICU length of stay, cost, the very bottom of those curves is really where there was the best outcomes. And when you then draw a line straight down from the lowest part of that curve, that is the ideal systolic blood pressure to create the best hospital length of stay, the shortest ICU length of stay, the most discharges to rehab, the lowest cost. It turns out that number is between 125 and 130. So they concluded out of 12,169 cases that when you look at that box goes from about 130 to 180. We're not telling you to go to 180, but we surely are saying that you should probably be somewhere between 120 and 130. And this concept of permissive hypotension with, again, not just any TBI, but just that middle category of severe TBI is very, very important. So let's go back to the case. Start all over again. 17-year-old kid, we talked about it, GCS of 3, fine. Obvious TBI, we're going to call it severe TBI because you got a GCS of 3. You can see that the patient's blood pressure is good for now, heart rate's okay, breathing 10. So therefore, we're going to leave that be because we got the 10. Now the SATs are okay, but what did we talk about first? What's the first thing you're going to do in this kid? It's throw on a non-rebreather. You're not going to intubate this patient right off the bat. It's not going to be the thing you do because you're going to put this kid into a worse situation based on the medications you end up using. Now, 5 minutes later, still breathing on his own. The SATs are now up because of non-rebreather, but you had a significant 40+ point drop of the systolic blood pressure, and you know that there's a huge danger in one episode of hypotension. So even though the blood pressure is above 90, the first thing you should say is we have to give fluids. And we talked about 20 per kilo. We talked about giving some of your protocols will say 500 like mine does. Some will say a liter, but you have to give the fluids, and you should not be just waiting until that blood pressure goes low. That rapid drop is what you need to be looking at. And obviously, if you have blood, you would give blood first in this case if you had it there. So just to summarize, and this is their poster, you can see that severe TBI without an advanced airway, you're doubling outcomes. If you intubate the severe TBI, which again, it's okay to do, just do it in the right order, you're tripling outcomes, avoiding the 3 H-bombs, making it very clear in your protocol what your expectations are is very, very important. So what about the kids, right? Because the EPIC trial, didn't have a carve out specifically at this particular point, at least reported. So there is something called the Pegasus Trial. 236 severe TBI patients, 5 trauma centers, and they looked at hypoxia and hypotension once again. And guess what? They looked at if the patient had early hypotension and they were treated, you could see that if there was no treatment, then none of them did well. If they were treated, they got 27% favorable outcome. But if there was no early hypotension at all, you could see that you had a 37.7% favorable outcome. So it doesn't matter if you're an adult, it doesn't matter if you're a kid, the brain needs a normal pressure to survive, to oxygenate the cells so that those cells don't die, swell up, you herniate, and you end up dying sometime later in the ICU. So just because you're bringing these patients in alive, if you skipped out on the non-rebreather or intubating them, if you skipped out on resuscitating them first with keeping their blood pressure up till the brain gets perfused, you end up in a patient who lives, but they're in rehab and they're in a vegetative state. If you're tracking your outcomes as an EMS system, don't track, did they live? Track, are they CPC 1 or 2 later on? All right, so now I want to talk about TXA. We talked about whole blood, but what about TXA? On the image here, you see a bunch of red blood cells, and you see what we call fibrin, which is interwoven into those red blood cells. Now, it turns out that there is the fibrin right in the middle, but the body wants to take that fibrin and it wants to break some of it down. And that's just how the body works. When you give TXA, if you look there on the right-hand side, it blocks plasminogen from connecting with TPA to create plasmin, and therefore the fibrin never gets broken down. So what does TXA do? It just keeps the clot around longer. And if you have to know these studies, right? Because CRASH 2 looked at death related to bleeding. And it's very important when you break out the timeliness of the TXA, you can see on the left-hand side that you're on the left side of the one. If you give TXA in less than an hour, it's a significant reduction in bleeding. If it's between 1 and 3 hours, it's better, but it wasn't statistically significant. The bottom line is you have to give these in quickly, and Mark alluded to that earlier. CRASH 3 came out and it looked at TXA in TBI. And again, it turns out that early TXA makes a big difference. And you can see that in the mild to moderate category, which is that very top line up on the top left, that TXA early makes a difference. And if you look at this graph on the right-hand side, the time to treatment for mild and moderate, the earlier you gave the TXA, the better the patient did. Speed is important here when it comes to TXA. Mark talked about this earlier. TXA, for every 15-minute delay, you're decreasing the survival by 10%. And there's another thing we've learned, which is this 1 in 1 of a gram now and then a gram either over 10 minutes or over 8 hours. That's got to go away. It turns out that giving the TXA up front for an adult 2 grams is the thing to do. And in children, 15 milligrams per kilogram. So real quickly, TXA in children, guess what? It works. And again, this is a study called PTRAX, which came out of the military. And you can see here that for all patients, TXA favored that child, improved numbers for the mortality with TXA. So there was a benefit there. Again, you can see here that on the left-hand side, did they get discharged with a GCS of less than 9? You can see that the TXA group in blue was improved. And also, did they get discharged with a CPC 1 or 2 or GCS of 14 to 15, also improved in the TXA group. So there is proof that that works. Other studies have shown that there's an in-hospital mortality with TXA with a p-value approaching 0.05. So there's a benefit with TXA in this study as well in kids. So in summary, in this section here, avoid the 3 H-bombs. Everyone gets oxygen as soon as you get onto the scene. That's a huge point. Don't hyperventilate. Just keep that end tidal CO2 somewhere around 40, between 35 and 45. Breathe them at 10. If they're breathing on their own at 10, just leave them be. They're okay. If they're an adult, 20 in children, 25 in infants. Give the 20 cc's per kilo. And the 90 systolic is too low. Again, for adults, we're talking a 120 to 130. And in children, instead of using that 70 plus 2 times the age, or in children 10 and above using 90, we're going to have to bump that number up. So use 80 plus 2 times the age for children, and then go to that 120 or 130 for adults. Use TXA 2 grams up front, hopefully quickly. And then in kids, your dose should be 15 milligrams per kilogram. So Mark, I know you wanted to end with this incredible story. So let's take it away.
Let's just wrap it up and just kind of remind ourselves that the partnership between our EMS providers and the hospital and the surgeons and everyone who can be involved in effective resuscitation can save lives. And this little guy was literally seconds from dying. Oh. And he needed rapid resuscitation, then good airway management, and then good surgical management. And he got all of it, is happy and healthy, still undergoing some facial reconstruction, as you can see, but is out there alive and loves life. And by the way, I have the permission from mom to share these images. So just a reminder of what we can do together when we focus on treating kids with severe traumatic injuries quickly and remembering that minutes matter.